Okay, I hope my English will be good enough. Don't hesitate to ask me questions if it's not clear. So I thank the organizers to invite me to come and talk about the NIPT for non-invasive prenatal testing. I would use NIPT or NIPS for screening, S for screening or T for testing. The same word, different than diagnosis. So NIPT started, the idea of NIPT started in the late 90s because in 1997 in Hong Kong, Dennis Low and his team discovered the presence of fetal free DNA in the maternal blood during the pregnancy. And in the early 2000s, there was NGS for new generation sequencing, which appeared in molecular biology laboratories. And NGS applied to circulating fetal DNA could drive to NIPT. Why would we practice NIPT? It is in order to test and to screen for the major trisomies, 13, 18, or 21. And we could have diagnosis with amniocentesis or chorionic virus sampling, but we know that those procedures can have some risk of fetal loss. So if we diminish the number of people who have amniocentesis, we'll have less fetal loss. And so we select them using NIPT. So what is this cell-free fetal DNA in maternal blood? This is cell-free DNA coming from the placenta. The placenta cells, when they die, they deliver DNA, no cells with DNA, but free DNA in the blood of the fetus, in the cord blood, and then it's joining the maternal blood flow. In the maternal blood flow, there is cell-free DNA coming from the mother, and it's added with the fetal free DNA. There's not the same amount of maternal free DNA and fetal free DNA. There's almost 80 to 98% of maternal free DNA in the maternal blood and 2 to 20% of fetal DNA. This percentage of fetal DNA is called fetal fraction, which I'll use later. So these fragments of fetal DNA are smaller than the mother's ones. There are 100 to 200 base pairs. And we could see that they appear in the maternal blood since week 7 of pregnancy. And the important thing is that this fetal free DNA disappears in the next hours after delivery. And of course, the test we'll practice on fetal DNA will be totally non-invasive for the fetus because we work on maternal blood. So this presence of fetal DNA in maternal blood was used in diagnosis to diagnose the fetal sex. We search for fragments of SRY gene in the maternal blood because the mother is female, of course, so there shouldn't be any fragment of SRY. If we find SRY fragments in the maternal blood, it means that the fetus is male. The same meaning for RHD genotyping. We do genotyping only for mothers who are RHD negative. So if we find parts of RHD gene in the mother's blood, it means that the fetus is positive. And for achondroplasia is an autosomal dominant illness, and there's a special mutation which shouldn't be present in the mother, otherwise we would know that she is achondroplasia. So this was detection of DNA sequences not present in the mother. With the NIPT for trisomies, we are looking for sequences which are shared by the mother and the fetus. It's a question of amount of these sequences. So technically, you would have heard about different companies who deliver NIPT techniques. So in the USA, there's Roche with Harmony test, which is mostly used in Ireland. There's Maternity 21 sequenom made also in the States. There is Illumina American test called Verify test, and there is Natera Panorama test practiced in the States. In Europe, there is Prenatal test from LifeCodex. LifeCodex is a German company held by also Eurofins. There is Iona test Prenatal, which is used in France and in some other countries. The very new test is Vanadis from PerkinElmer and our test. And in China, there is NIPT test from BGI company. The big difference between those different tests is the technology used. We use genome-wide sequencing. Genome-wide sequencing means that we are sequencing the whole genome. Here you have the representation of the different chromosomes. You have the 23 pairs of chromosomes. And the sequencing is breaking the DNA in very small parts of the genome. And we know that each part belongs to, this part belongs to chromosome 2, this red part belongs to chromosome 5, and so on. And we are counting the fragments coming from each of the chromosomes of interest. So genome-wide sequencing is used by our technology, Illumina, and for prenatal. There's another way of sequencing, is targeted sequencing. You sequence only the chromosomes of interest. For instance, 13, 18, and 21, not whole genome sequencing, targeted sequencing. This is made by Natera and Agilent. And there are non-sequencing methodologies, microarray technology used by Roche in Harmony, and RCA for rolling cycle amplification targeted, for instance, by PerkinElmer, which has just arrived in the market. So 3 main different technologies to get quite the same result, but not exactly. So here the different companies also in a table. So we use Illumina. I will describe it in the next slides. We can provide information about the most important trisomies, 13, 18, and 21. We can look for a sex chromosome aneuploidies for some microdeletion, but not all. I will have a point about it. And we can look for genome-wide aneuploidies. We can look for, it will be possible in the next month. Only in March, we'll have a new software with which we'll be able to look for other autosomic aneuploidies other than 13, 18, and 21. And we have a very low failure rate, and the test is confident even at low fetal fraction. Fetal fraction is what I told you, the percentage of cell-free DNA coming from the fetus in the maternal blood. Our test can be offered to women with a singleton pregnancy, of course, but also with twin pregnancy, with pregnancy initially twin, but with a vanishing twin, and egg donor pregnancy, which is not possible, for instance, with Natera. So we usually give you results for standard NIPT screen for trisomy 21, 18, and 13. Sometimes, if the woman wants to, you can have an option on sex chromosome aneuploidy. And next month, we'll be able to propose you rare autosomal aneuploidy, for instance, trisomy 16, and genome-wide partial deletions and duplications, but only above 7 megabases. So we calculate the size of the deletions in megabases, or 100 of bases, but here we would be able to detect duplications and deletions over 7 megabases. So what happens in the lab? Very shortly, we get the maternal blood. In the maternal blood, there are red blood cells, white blood cells, platelets, and there are some molecules of free DNA here. We'll extract maternal and fetal free DNA, and then we'll go in the first machine, which will prepare the samples, quantification of the DNA, and pooling of the different samples. And then there will be the true sequencing in this sequencer from Elementa called NextSeq sequencer. And then what is sequencing? I told you it's breaking DNA in very small fragments, and the machine the software can know for each fragment from which chromosome it comes from. So we will have a certain amount of fragments coming from a target chromosome, for instance 21, and a certain amount of fragments coming from another chromosome that the software chooses as reference chromosome. And then there's a calculation of a NCV, normalized chromosome value, which allows to give a final result with a CE-IVD marked software. So this is what happens in the lab. What is interesting for you is the results and the cases where you use this test. Performance and limits of this test. So it started in 2011 in the States and arrived for us in France in 2014. So in 2017, there was a meta-analysis from worldwide, which showed that the detection rate for trisomy 21 is 99.7% for trisomy 21, 98.2% for trisomy 18, and 99% for trisomy 13. So very good detection rates for all those three trisomies. Take care of the predictive positive value, which is not the same depending on the chromosomes. For chromosome 21, it's very good. It's 99%. So if we give you a positive result for trisomy 21, there's 99% of chance, if you can say, to have a real trisomy 21. But with trisomy 18, there's only two-thirds to three-fourths chances to have a true trisomy 18, and even less for trisomy 13. So it's a screening test. We propose it in the whole population, and we have to select an at-risk population. It's not a diagnosis test. If you want to have a diagnosis, you have to practice amniocentesis or chorionic virus sampling. So anyway, even for trisomy 21, if you have 99% of positive predictive value, if you have any NIPS positive, you have to control it with amniocentesis. The diagnosis is by amniocentesis. We have some limits for any test. So there are some false positive possibilities. If there is a vanishing twin, maybe the vanishing twin was affected by trisomy, and its placenta still delivers DNA with trisomy in the maternal blood, whereas the survivor is safe. So if there is vanishing twin, there could be false positive. There could be confined placental mosaicism. If you are used with CVS test, there's a possibility that you find an abnormality in the placenta which is not found in the amniocentesis, in the amniotic fluid. So there could be a discrepancy because when you practice an NIPT, you work on placental DNA, not on fetal direct DNA. It's on placental DNA, so you could have the same discrepancy as between CVS and amniotic fluid. Maternal CNV, this is copy number variant. If the mother has a different amount of chromosome 21 without any phenotype, it could make a false positive. And if the mother is affected by a neoplasm, neoplasm can deliver also its DNA, its cell-free DNA. So there's a mix between mother cell-free DNA, fetal cell-free DNA, and neoplasm cell-free DNA. So it could make a false positive also. For the false negatives, there could be a fetal-placental discrepancy, same as here, but in the other side. There could be low levels of fetal DNA. I told you about this fetal fraction. If there is too low amount of fetal DNA in the maternal blood, we couldn't detect the trisomy. And for triploidy cannot be detected with our test. Our test is comparing the amount of chromosome 21 to 18 or 13 with another chromosome, which is reference chromosome. If you have a triploidy, all the chromosomes are in 3 samples. So there's no discrepancy between 21 and the others. So this problem of low fetal fraction is overwhelmed with 9 area, which use another quality control, which is called IFACT, for individualized fetal aneuploidy confidence test. This decided of a threshold for each sample, which takes in account the fetal fraction, but also the the quality control of the sequencing itself, which are called coverage or depth. And there is all these features together can give a good quality metric, good IFACT or no. If there is a bad IFACT, the machine doesn't give any result, and it's a no-call result, and we signal it. And as for us, we advise you to practice another blood sampling. This second blood sampling will not be charged to the patient, but it will allow in many cases to have a good result. So in the States, because they started in 2011, they gave some guidelines for this test. So I won't read all the sentences, but they say to propose this test to all women, but to discuss with them the option they want to have. It's not an NIPT for all women or amniocentesis for all women or all couples. It has to be discussed with them, and we have to propose them the best option for their personal goals. We have to inform patients that diagnosis testing with CVS or amniocentesis is an option. We have to inform them that NIPS or NIPT is a most sensitive screening option and not diagnosis option. And refer patients to a trained genetics professional when there is an increased risk of aneuploidy after NIPS, and offer diagnosis testing, as I told you, if it's positive in NIPS. Never a termination of pregnancy after only NIPS. We have to inform all women that it's possible to look for sex chromosome aneuploidies, but with caution, because there are more false positive, even more than for trisomy 13, in sex chromosomes aneuploidy. The patient must be informed. And they have to be informed also that even if there is then a diagnosis of Turner or Klinefelter, the phenotype can be very different from one baby to another. So sex chromosome aneuploidy can be an issue for genetic counseling. Trisomy 21, 18, 13, we know how will be the baby, but for sex chromosome aneuploidy, there are many questions will remain after the diagnosis. Women who have a no-call test result from DNA screening should have genetic counseling and be offered comprehensive ultrasound evaluation and diagnosis testing. Be sure that the cfDNA is not maternal serum screening. In maternal serum screening at the second trimester, you can screen for open neural defect. It's not made by cfDNA. cfDNA is only for anomalies in genes. And cell-free DNA screening for microdeletions was not yet validated clinically. Natera proposes it, but it's quite good for Dijon syndrome, but for the others, there's too low positive predictive value. So you can propose NIPT for any pregnant woman out of the ones who have warning signs on ultrasound or nuchal translucency at the first trimester over It was decided 3.5 millimeters. It could be 3, but there was a cutoff fixed at 3.5 millimeters. In those cases, you have to go directly to invasive procedure, then to have a whole chromosome analysis with array CGH or fetal karyotyping. No NIPS if there is anything abnormal on ultrasound at the first trimester. So in routine practice, we started at Eurofins Biomnis in October 2014. We now have made almost 100,000 tests. It was 91,000 tests in October. We find around 1% positive trisomy 21, or much less trisomy 18 positive, trisomy 13 positive. We have a no-call rate at 1.15%. We have some false positive for trisomy 21. I said that the positive predictive value was 99%, but we had also in 5 years 4 false negatives. So if there is a negative result, there must be also watching by ultrasound. So if we give you a positive result, means in favor of trisomy 21 or 18 or 13, we contact the prescriber or the lab who sent us the sample, and it means that there's a strong chance that the fetus is affected, but it has to be confirmed by amniocentesis. If we give a negative result, the risk is very low, but not zero, so go on taking care of the patient. And in very rare cases, there is no core result. You have to discuss, or you can also contact Eurofins, and they will contact us to try to give you some more information. With the new software next month, we should have even less no core results. So practical details, you can have a request form where you give information about the patient, about the prescriber, information about the pregnancy, which test you want to use. I told you about Nenalia test. We have also in Eurofins another test which is searching only for trisomy 21, which is called prenatal test. You choose the test you want, and very important, the consent form must be signed by the professional and by the pregnant woman. We have all the information here. The woman should read before signing. So there's a sample. The sampling, blood sampling must be on a special tube which is called Strake. It's 10 milliliter Strake tube. Must be sent at room temperature. The method is a new generation sequencing. The turnaround time is 8 working days, and so sample must be delivered to Eurofins Biomnis Ireland. You have here the phone number, and I give you the website also next slide. And you have to follow we send you the tube, the special tube, we send you the tube, and you send them back to Eurofins Biomnis. The Nenalia test price is 299 euros, the one we propose now with trisomy 13, 18, 21, and even sex chromosome aneuploidies. In next month, maybe a bit more expensive if we do expanded test on genome-wide, but you will have information of this website, eurofins.ie Biomnis. So I'll finish with a bit delay, sorry. So this NIPT is based on detection of circulating fetal DNA in conjunction with molecular biology with a new generation sequencing. It's the best screening method in terms of sensitivity and specificity. It's a non-invasive test because it's only a maternal blood drawing. There is a low failure rate, 1.15%. It's mostly used for detection of trisomy 13, 18, 21, and sex chromosome aneuploidy, but in the next month we'll be able to propose you also detection of rare autosomal trisomies and duplications of deletions above 7 megabases. Thank you for attention.